Okay, so liver failure, super thrilling and unfortunately really common, really common. So, okay, I'll go to this side so that I can reach the things. Is that acceptable to Dallas?
Yeah, that's perfect. Yeah.
Okay.
I might actually switch angles.
Really common basic stats from Canada, but like 1 in 10 have some form of liver disease, which is pretty common, and it's also in the top 10 most common causes of death in Canada. So I don't know that people realize how actually significant liver disease is, and a lot of people, when we think about liver disease and cirrhosis, we go like, oh, right to this one part, but it's actually a huge spectrum of diseases. Again, I'm not going to talk about necessarily the workup and all the different categories, but you'll get a hint of it. And then again, cirrhosis being one type of liver failure, and usually the progression of it. So I sort of wanted to get a bit into the terminology that you're going to see around. And so like there's healthy liver, and then you get into this fatty liver disease. And actually, just in the last couple of years, alcoholic liver disease has now been surpassed by fatty liver disease and metabolic syndrome as the most common cause of cirrhosis. So, alcohol, we have new guidelines around, we're getting better and better, still have lots of work to do in alcohol use disorder, but also like metabolic health is such an important part of that, leads to fatty liver in the same pathophysiology. So with that fatty liver, the liver is an organ that does regenerate its cells. And so as it continues to do that, you can get some progressive scarring and abnormal cellular development that leads to fibrotic liver and ultimately a diagnosis of cirrhosis, which is a big umbrella term for many different diseases. And that cirrhosis, again, as cells continue to regenerate in an abnormal pathway, is how you end up with hepatocellular carcinoma, which is one of the end-stage complications of liver disease and cirrhosis. So that's sort of very broadly why I struggled with this, is because it is such a big topic. But again, just to give you some of the most common terms that we use, you're going to hear people talk about hepatitis, which is elevated liver enzymes, and a liver injury, right? Not necessarily liver failure or cirrhosis, but a hepatitis. And again, hepatitis is a umbrella term for then viral hepatitis, drug-induced hepatitis, like et cetera, right? So you can see that they can range from mild being anything like above the normal range. So you can have an ALT of 70. That's hepatitis, and that might be steatohepatitis, which is fatty liver, okay? Or you can have this thousands club, ALT over 1,000, sometimes 3,000, 5,000. That is a severe liver injury, usually goes along with acute liver failure, which is a very specific term, and that's where you see like Tylenol overdoses or ischemic liver, or Budd-Chiari, which is a blood clot in the liver. So a huge liver injury, immediate liver failure potentially. So again, a range, but you'll see those terms, hepatitis versus elevated liver enzymes. Acute liver failure is actually a very specific definition, and I'm going to talk to you about what the functions of the liver are and why it's actually needs to be that specific. And those are the patients that we start talking about. Your liver is failing quickly for a couple of specific reasons, and we need to talk about transplant for you early. Okay, so the criteria we talk about, so you have a big liver injury, so usually a hepatitis in this context, an INR greater than 1.5, hepatic encephalopathy, and we'll talk more about what exactly that means, and then no previous liver disease. So again, most common cause in Canada is Tylenol overdose leading to acute liver failure or a drug-induced liver injury, sometimes autoimmune hepatitis and pregnancy-related complications. Those are in that category. It's very specific. I'm not going to talk a lot more about acute liver failure in this conversation, because much more common that we see is cirrhosis and chronic liver disease, and that's where we talk about, you saw the spectrum of, is it cirrhosis versus just fibrotic liver? We'll talk about that. And then when we talk about cirrhosis, you can have well-compensated cirrhosis or decompensated cirrhosis, which are the people you're going to see in the hospital. Okay? So again, this is just to represent to you how much of an umbrella term these words actually are. So hepatitis or elevated liver enzymes have all of these different causes and then some. You don't need to know this. I'm not going to spend any more time on this slide, but just like it's a very, very broad reason, and that's mostly what we do in med school is what's the differential diagnosis for hepatitis, right? And here's the workup I'm going to do. So I don't know if that's as useful for you guys, but you're going to start to see like why we order these extensive tests when we see these weird tests come back. And similarly, like acute liver failure, Tylenol, drug reaction, Hep A and B usually will get you into those 1,000 club liver enzymes. Autoimmune hepatitis, which is incredibly common in Vancouver Island specifically, 8 times more common than the rest of Canada and the rest of the world. So we have a huge population of autoimmune hepatitis, particularly in our Indigenous populations. So again, often a little bit comorbid with alcohol use and underserved populations who often get misdiagnosed. Okay, so yeah, there's other, again, genetic causes, but you can see acute liver failure is super broad topic, right? And then the same with cirrhosis, right? There's many causes of cirrhosis. So alcohol-related cirrhosis is one of the most common ones that we see, but any injury, in terms of like if you have hepatitis C, which tends to be more chronic rather than acute hepatitis, you're going to start to see scarring, right? And there's that non-alcoholic fatty liver disease. We now call it metabolic associated liver disease. Primary biliary cirrhosis, which again, that is autoimmune hepatitis, which is super common out here. And so also things that are not liver related at all. Chronic heart failure can sometimes lead to extra congestion, liver injury, damage. So it could be a consequence of a different disease that we're seeing. So cirrhosis, very broad umbrella term. Okay, so let's talk about the functions of the liver. And then down the road, we're going to talk about like what happens when these functions start to fail and what you might actually see in practice in your visit. And again, this is mostly going to relate more to that decompensated cirrhosis patient. Acute liver failure, it still applies, but it tends to happen more rapid. And you'll see some things more than others. So let's talk about Krebs cycle. But when you so when you talk about liver, I split it into 2 categories. Okay, you have the synthetic liver function, and then you have the portal blood flow supply. And so when we talk about synthetic functions of the liver, there's like innumerable thousands of things that happen in hepatocytes. This being one cholesterol pathway, right? So the liver is responsible for the synthesis and metabolism of most of the proteins in your body, like 85% of the proteins in your body. And that includes several immune systems. Specifically, there's a cell called the Kupffer cell, which is responsible for a large part of the innate immune system that exists within the liver, okay? It's responsible for, again, generating some of those like blood clotting proteins, as well as the anticoagulant proteins that naturally exist in your body, right? Everybody has a normal balance of bleeding and clotting, and you have to have innate anticoagulants as well as clotting factors so that you don't bleed out but you don't clot all the time, right? So the liver does both. There's some proteins that it doesn't do, so it doesn't do factor 8, which is like hemophilia, right? So that's not that liver disease, but the anticoagulant proteins are protein CNS, if you ever see those or hear those. Those are the ones we're thinking about. Albumin is one of the main proteins that we can measure in the body. And so, again, I pointed out there, but also all the other hormone or binding proteins, so sex hormone binding globulin, which again, I'm going to come back to when you see some of the symptoms of cirrhosis. Gluconeogenesis and the process of like maintaining your Blood sugar control, it has a large portion of role in, although there's many other pieces to that picture. And then also it creates thrombopoietin, which is a protein that stimulates platelet generation. So kidneys and adrenal glands are responsible for erythropoietin, or EPO. So a lot of you will be familiar with that. It increases, there you go, I saw some nods back there. So that comes from kidneys versus thrombopoietin, so platelet specific stimulant protein comes from the liver. So lots of synthetic functions that we start to think about and look at. The other normal function of the liver is the blood flow. And so this is a sort of structure of one sinusoid within the liver made up of a variety, like many different hepatocytes. Okay? So you can see the network there that allows blood to process and filter through that like really complex network of cells. And that's why it is so important in filtering the blood. So remember that, like we talk about, everyone's familiar with this picture of the liver down in the corner, but remember that those blood vessels come from the gut, right? So whatever you eat gets processed in the gut, and that blood flow goes directly to the liver. Like that is the portal venous system. And so everything that you're processing, the dietary things that you make, the cholesterol gets into the liver, and you saw that pathway, but also ammonia being one of the breakdown products of nitrogen fixing bacteria, which live in the gut. So we'll come back to ammonia. The hint is hepatic encephalopathy theory, but is responsible for that. It's responsible for, in addition to the spleen, like filtering some of the white blood cells and red blood cells that are breaking down naturally in your body, which leads to bilirubin issues. And then it's responsible for, this portal hypertension comment is more of like, it's a low pressure system most of the time, right? Remember, it's a venous system, so it should flow quite freely as opposed to a high pressure arterial system. And so as you get fibrosis and cirrhosis of these cells, that's when you start to increase the pressure in the portal system. And so portal hypertension versus synthetic function, these are the two big categories of liver function, okay? And again, we're going to talk about these complications a lot more. I'll tell you, liver, so ALT is the most important one most of the time for me. It is very specific to the hepatocytes. So it goes up if the liver is truly injured, ALT. AST, so remember L for liver, AST stands for a shitty test. Don't put that on, don't put that on YouTube or anything.
No.
But it's super non-specific, right? All it tells you is that it's like damage to a lot of stuff. It could be anything, right? So your AST will go up if your heart is injured, if your muscles are injured, similar to something like LDH, right? It's sort of a non-specific marker. The only reason I order that is to get a ratio up front, which sometimes helps in the diagnosis, right? So you will see AST much higher than ALT, often at a 2-to-1 ratio in alcohol or ischemic related liver injury, because there's more inflammation and injury happening. Tylenol is a similar pattern, as opposed to your like viral hepatitis. You might see a closer or a less kind of numbers, okay? So AST, ALT I want once, and then like really I only need the ALT after that. Same thing goes for ALK, Phos, and GGT. So those are more cholestatic enzymes. You probably have heard those terms, but they mark more of the gallbladder, right? So GGT tends to be specific to the gallbladder, but ALK, Phos is actually much more representative of the injury going on. So GGT goes way high and you don't really know what that means. And so ALK, Phos, you want to go up, or if you see it going up, it's likely liver, but you have to confirm that with the GGT, because if the GGT is normal and the ALK, Phos is up, that could be bone or breast or something else, okay? Vitamin D deficiency, calcium. So ALK, Phos is less specific, but more reflective of the actual process once you confirm that it's coming from the liver, which is why you need the GGT. Does that make sense what I just said there? Did everyone?
Yes.
Yeah. Okay. So like that's what we talk about when we talk about the full liver panel, and then sometimes we'll throw lipase in there. Hepatocellular injury, more liver. Cholestatic injury tends to be more gallbladder or structural conditions. It's not a perfect rule, but that's often the patterns you're looking for in these tests. And then you want to know, has the function of the liver been impaired? Those other tests, okay? Well, okay, big slide. So let's talk about cirrhosis, which is really chronic liver failure, much more common stuff that you're going to see day to day. And like you said, it's scarring, it's fibrosis over time with synthetic dysfunction and or portal hypertension. Okay, so that is what cirrhosis means. And then you can have compensated or decompensated cirrhosis of a variety of different stages. And so we tend to, again, measure the function of the liver to assist in identifying the stage that you're at. We use the Child-Pugh score and the MELD sodium scores. You'll see those written in notes. And again, those are prognostic measures and also reflective of when you're at Child-Pugh, the A, B, and C. When you get to B, we really should be starting the process of talking about transplant, because that's the perfect time to transplant. When you're at stage C, you have passed the point of successful transplant, okay? But you have to be in a compensated state for that to be accurate, because decompensated cirrhosis are going to have much higher scoring, stuff like that. So you'll see those kinds of things all around and just know they exist, really. But this comes back to, again, we just talked about the function of the liver, so you can now expect what the complications of cirrhotic liver is. And so you'll see, I didn't pick a good picture here, sorry, but mostly like inflammatory, so you can be at risk for infections more than others, right? This population tends to get more pneumonias, more bacteremias, more infections in general, because their innate immune system starts to get impaired. You can get ascites, and ascites essentially comes, again, we'll talk more about it, but from that portal hypertension, less blood flow is able to pass through the liver. The liver literally like weeps fluid into the belly because of the pressures there, and that makes ascites. You get increased INRs. Prothrombin time is then made into INR through the lab test. So you get INR starting to go up, coagulopathies, you get varices, you can get encephalopathies. Okay, so the other things, this is actually what I wanted to show in the picture and I just picked the wrong one. In cirrhosis, you can get jaundice, and you can get proximal muscle wasting, which is a reflection of decreased androgens. You can get telangiectasias over your face. You can get shrinking of the testicles, which is also something that isn't often talked about, right? And actually an erectile dysfunction. So all sorts of other complications that are related to, again, the function of the liver. Okay. And now just kind of a one-slider on the complications and what to expect and sort of why we do stuff. And then question time. So yeah, ascites plus or minus SBP, and what I mean by that is spontaneous bacterial peritonitis. It's a term you may have heard before. So spoke about ascites. Now, remember that ascites is a symptom. It is not a disease or a diagnosis, right? So yes, cirrhosis causes ascites, but so do many other things, including heart failure, nephrotic syndrome, cancer, like many other things. So anyone who comes in with new ascites needs a diagnostic procedure, and then we do a whole bunch of extra tests to see, did the ascites come from cirrhosis or something else? Okay, so that's step one. It's a symptom. Now, what people can get, so you can get a little bit of ascites, you manage that with diuretics and low salt to try to relieve the pressures there. You can get lots of ascites and tense ascites, and those populations or those people can have a hard time moving their diaphragm, and they come in with respiratory distress because their belly has 12 liters in that, right? So those people get both a diagnostic and a therapeutic paracentesis. There's a lot of guidelines within kind of our orders that tell us if we take this much fluid, they must get this much albumin back, because you can imagine if we take 12 liters out of a belly and there's no protein circulating in the blood, it's just going to go right back into the belly, and you're going to make that person intravascularly deplete. You're going to drop their blood pressures, you're going to cause kidney injuries and stuff like that. So we have a lot of albumin supplementation, which you'll see around the time of paracentesis. Okay? There's no perfect rule, but there's a lot of guidelines that exist around that, and that's what you're going to see commonly. Spontaneous bacterial peritonitis is a complication of ascites, and so often what happens is there's lots of fluid and edema. Anytime any fluid is sitting static in the body, there's risk for infection, right? Whether it's fluid in the lungs, a pleural effusion can get, it's just static there. You can get an empyema or parapneumonic effusion. Ascites is one of the most common. There also tends to be some gut edema. So the theory that we have right now is that bacteria translocates through the gut wall, through the tiny little spaces. And there's like this nice little warm fluid hanging out, and it just grows there, right? So you end up getting, we call it spontaneous, but bacterial infection of the acidic fluid and the peritoneum. They come in with a lot of tenderness in the belly. So you can have ascites that's uncomfortable, and then you can have peritonitic ascites, okay? So that's why, and sometimes it's super subtle. So people who have ascites, if they come in and they're sick, we have to do that little therapeutic or diagnostic tap to see if there's infection there, because they're so at risk for infection and they're decompensated in the hospital. That's what's going on, okay? They get treated very low threshold to give them antibiotics right up front until we know whether or not it's infected fluid, okay? Questions about ascites and SBP? There is sort of a down the road, like if they come in and they have known cirrhosis, and you confirmed that, and then they're having ongoing diuretic resistant ascites, you can do regular paracentesis and then eventually TIPS and then eventually transplant. TIPS is a procedure that bypasses that pressure basically. So it puts in a shunt, a transhepatic intravascular portal hepatic shunt, TIPS, okay? But yeah, you basically they'll put like one little piece in the gut and they'll bypass the portal vein and they go right into the IVC, and they like something like that. It's obviously more complex, I don't do it myself. But that's the idea, to relieve the pressures in there, okay? Next complication, the coagulopathy. So like I said, the INR is the best way to represent that, but you also have to remember that they are not making both types of proteins. So these guys are at risk for bleeding and clotting, okay? And any dysregulation can be like a nightmare. So what happens is, again, also contributing to this, with this portal hypertension, one of the complications of that is that their spleen starts to get bigger because there's more pressure there. So you're going to see splenomegaly in a lot of patients with cirrhosis, and that makes their platelets go down. So they're not making thrombopoietin, their spleen's getting bigger, their platelets are going down, and they're not making bleeding and clotting proteins. So like this is all bad news for them, right? And then the other thing, again, one of those clotting proteins is fibrinogen. So this is when we start to add the fibrinogen to the full coags. You might see that sometimes. What we are looking for is disseminated intravascular coagulopathy. That is a very dangerous situation where people get high rates of bleeding and high rates of clotting, okay? So we have a very low threshold to replace fibrinogen because the liver is not able to make it very well, and it can become a cascade of bleeding, clotting problems. And you can imagine if you're getting blood clots, it's really hard to put people on blood thinners if they're also bleeding, and that's how people die. So DIC is a catastrophic event usually, and so we are always on the lookout for it when people decompensate. Okay? Again, those people are in the ICU and they often have ischemic digits and DVTs and bleeding in their Foley bags and all sorts of stuff like that. So hopefully you don't have to ever see it, but if you do, that's what we're looking for when we order fibrinogen. Yeah. So we monitor the INR. We monitor their hemoglobin and their platelets, and we order fibrinogens. And to mitigate risks, some of them will be on PPIs depending on their context. Right? It depends on the underlying disease, their own risk factors, their own history. Some, they should be on DVT prophylaxis in the hospital unless they're actively bleeding. Right? So some people will say, well, their INR is high, we shouldn't have them on DVT prophylaxis, and that's not correct. We definitely should have them, because remember, it's a balance problem. And then we screen for varices. So we haven't fully talked about varices. You can see liver is so complex, right? But that portal hypertension component of it, if I go back to, oh, maybe I did put a picture there. I'll see. But if you go back to this picture, right, and you have the liver here, remember the blood vessels go directly to the stomach and the esophagus, as well as the gut blood vessels. And so if you have high pressures and blood's not filtering through very well, then the blood vessels below are going to get engorged and dilated. Right? So these thin-walled veins become very large, and they sit right in the esophagus, the stomach, the gut, and often the anus, right? So people can have hemorrhoidal bleeding, which in cirrhotic patients can be very severe, but also esophageal varices and gastric varices, versus portal gastropathy is the term we use, just to say their stomach is oozy because of all of these blood vessels. And so you can see they're so bleedy. So we screen for that as best we can. And again, by the point that there are guidelines, Child-Pugh B and Child-Pugh C cirrhosis, like we are doing surveillance screening often annually, sometimes even more often than that. We banned the esophageal varices before they bleed. We put people on beta blockers before they bleed to try to reduce the impulse into those blood vessels. Okay? And again, vitamin K is not done routinely, but it's done if someone's actively bleeding, or if you want to know how much of their coagulopathy is related to just the liver, or if there's a nutritional component to it as well. So those kinds of things are what we do. I'm not going to talk further about like the massive hemorrhage protocols and how to actually manage the variceal bleeding if it happens, but if you have questions, we can talk about it at the end. Infection we've sort of already talked about because they are at a lower immune system function just innately. So we have very low thresholds to culture and do like full culture panels, full infection workups for this population, and empirically start antibiotics. Okay, and again, if they've had SBP, they probably should be on SBP prophylaxis going forward because the infection recurrence rates are so high. Those are within our guidelines, but yeah. Oh yeah, there, I did put a comment on it. So GI bleeding, one of the bigger and scarier complications in cirrhosis. So this is what I mentioned with portal gastropathy. You can see the stomach blood vessels there. And again, if they do have the etiology of alcohol-related liver disease, then often there's alcohol injury in those blood vessels as well in the stomach, and so high risk for bleeding incidents, and those are the patients I put on PPIs prophylactically. And yeah, they can get these blood vessels, they go around the esophagus, and you can actually, when you do the scope, see them popping into the esophagus. It's pretty gnarly. The most important thing, other than obviously stopping the bleeding, is to give patients who are bleeding antibiotics. So ceftriaxone is actually what saves lives in variceal bleeding if they survive their bleeding event. Okay? The reason for that is similar to what we just spoke about with ascites, there is a very, very high rate of bacteremia as a result of variceal bleeding. So you have direct contact with like the gut and the blood vessels, and the translocation potential is incredibly high. And so if we can stop the bleeding, they needed to have antibiotics to try to prevent that translocation event. So, you know, if you have a patient and you're having a variceal bleed, 1 dose of ceftriaxone right up front lasts for 24 hours, might save their life if they survive the event. Right? But yeah, otherwise, like if they're truly bleeding, we do our best to reverse anticoagulation or their coagulopathy. We give them blood products. We talk to IR about embolizing or emergency tips procedures. We transfer them. We do endoscopy and try to stop the bleeding with emergency banding, stuff like that. So those are the things you will see. Okay, encephalopathy, another complication of liver disease. So this one is an interesting one in that it actually is pretty specific diagnosis, and so when really important for me to hear from you guys the level of consciousness in a useful way. And what I mean by that is like they're altered, like doesn't tell me anything. So what we want to see is like, are they alert, drowsy, obtunded, and not rousable? Like those are really helpful to communicate when you're assessing your patients to help us decide, is this encephalopathy versus delirium, those kinds of things, right? What is encephalopathy? We think we can't, biopsy brains on everybody, so there's still a lot of theories out there. One of the best theories we have is that there's a accumulation of toxins that are not being processed in the liver, often from the gut, right? One of the most common ones being ammonia. And so whatever it is that your bacteria in your gut are breaking down, often bacteria does produce a degree of nitrogen and ammonia processes or proteins, and that can lead to actually swelling the brain. In the acute setting, so the ammonia actually causes some swelling of specific cells called astrocytes in the brain, and then if you get a lot of them, you actually get obtundation and herniation. So super dangerous event. It's not just like a little bit of drowsiness. Okay. Having said that, we need to pay attention to drowsiness because it could be so many other things for these patients, right? You're hearing how high risk they are for other stuff and infections and things, right? So the most important thing that's helpful in encephalopathy is their attention and ability to do something that you ask. So when I ask them to do, when I look for asterixis, which is a pretty specific finding, where you're looking for, have you guys heard about this, asterixis? Have you heard that term? No? So basically you tell the patient, put your hands out in front of you like you're gonna stop a bus, right? And you want them to have some flexion there. And what you're looking for is, it used to be called the liver flap, right? But what happens is it's not the downward motion, it's that they sort of stop focusing on keeping their hands up. So they do this and then I have to keep it up, right? And that's what's happening is asterixis. You really see that in hepatic encephalopathy, carbon dioxide toxicity, so CO2 patients, and end-stage kidney failure patients who are uremic. Those are the 3 conditions you'll see that in. So asterixis, very helpful if you can see it, identify it, provoke that in your patient. Okay? If you can't, that's okay. They're drowsy and confused and all that stuff, right? So it's still helpful to know. And again, because it is such a dangerous complication, we really want to prevent it, and so we're very aggressive in pretty much the only thing we have as a tool to prevent it, which is diarrhea. Right? Mm-hmm. And we mean it, diarrhea. 3-4 loose bowel movements a day is the target. It's the only tool that we have in our toolbox to excrete this toxin that we think is happening, right? And it has been effective and studied, and that's what we've got. So it's probably the worst thing that I do to nurses is I'm sorry, but yes, we really have to get this in them. Lactulose is the first line. It increases it lowers the pH of the colon or increases the acidity of the colon, which helps with some of that nitrogen fixing, and then you can excrete it. But PEG has been shown to be effective, so if they won't drink lactulose, you can still use PEG. And then we give enemas, and then we put NGs in, and we force feed lactulose for that reason, because again, this is life-saving and brain-saving if we are in that stage. Rifaximin theoretically reduces the bacteria in the gut that cause that. So if they have had hepatic encephalopathy, then yes, we will start that and get some special authority for it. And again, you can actually look up, there is a degree of encephalopathy. I didn't put it in here, but it's like there's early stage, which is really just wake-night reversal, and then you get to the asterixis, and then you get to obtundation. So you guys can look that up on your own. Oh yeah, and then like if they're truly, truly obtunded, head goes to 30 degrees, right? Number one, it reduces the degree of swelling and pressure, and number two, it reduces risk of aspiration in an obtunded patient. Okay. Okay. Please don't confuse this with Wernicke's encephalopathy. Often there's overlap in certain patient populations, but this is an alcohol-related side effect or consequence of nutrition deficiency and thiamine deficiency. Okay, so often there's overlap, but they are very different things. So Wernicke's encephalopathy is not cirrhosis and liver failure. It is a combination of ataxia, disorientation and confusion, confabulation, eye movement palsies that you definitely will see in heavy alcohol use and patients with cirrhosis because of alcohol use, but it's very different than true hepatic encephalopathy. Okay, so separated that. Okay, I'm almost done. Oh, I went way long, sorry. Hypoglycemia, we sort of just mentioned, this is end stage. This is super poor prognosis, but again, if you see an obtunded cirrhotic patient, you should check their glucose. And then hepatorenal syndrome, I won't spend a lot of time on, but it comes down to huge volume shifts and incident, and again, it's often a very poor prognosis. And it's the thing to note for you guys is that patients who have cirrhosis often have low muscle mass, so their creatinines are often in the 20s and 30s. So if you see a normal creatinine of 60, it may be double their baseline, which is an AKI, right? And so normal does not always mean normal, and so do look at the trends that you're seeing. Okay. And then we sort of already mentioned hepatocellular carcinoma issues at advanced stage cirrhosis. They get Q6 month screening because this is a big complication as well. So that's the summary. Like, it's a huge, huge, huge topic, and there's many causes, but like the most important branch points are acute and chronic, and then compensated and decompensated. And then like we talked about lots of the things that you might see in terms of the complications. I think that was all I had. Yeah.